20 to 30% have fixed hip fracture mortality within 1 year of treatment of the fracture. So roughly 20%
Sir,
have the
you are
treatment
not
failed.
audible. Your
You're
voice
not,
is not coming.
I'm not
Hello.
audible, is it? Okay.
Sir, you are not audible.
Now,
No, sir.
now, can you hear me? Hello, can you hear me?
No, sir. Your voice is not coming.
Can you hear me? Can you hear me? Can you hear me? Can you hear me? Hello, can you hear me?
Yes, sir.
Can you
Yes, yes,
hear
sir.
me?
Yes, sir. We can hear you, sir.
Yes, sir. Yes, sir.
Now
Go
you
ahead.
audible, sir.
Now I'm audible.
Yeah, yeah.
Audible, audible.
Yes.
Audible, sir.
The fracture burden is about 200 million per people, which is affected by a silent epidemic, that is osteoporosis, and about 30% have fixed fracture mortality. 1 in 3 women and 1 in 5 women over the age of 50 will sustain fracture, fragility fracture, and 50% of these fracture survivors never gain prior functional status. So the treatment gap is the greatest clinical challenge. What is antiresorptive therapy? Normally, I think the previous lectures we have seen the bone is formed and bone is continuously resorbed. It's never a static phase. So an anti-resorptive drug is the one. In an osteoporosis, the resorption is more. So the anti-resorptive agents reduce the osteoclast mediated bone resorption, shifting the remodeling balance towards net bone preservation and gain. The drug classes or the bisphosphonates, namely the alendronate, risedronate, zoledronate, and ibandronate, and denosumab, the rank ligand inhibitor, selective estrogen receptor modulators, namely the relaxifene, the calcitonin, and the hormone replacement therapy. The distinct from osteoanabolic agent, that is the teriparatide and alboparatide and romosumab, antiresorptive and anabolics are often deployed sequentially. So what we are seeing are the drugs which prevent the bone loss, and the drugs which make the bone or the osteoanabolic agent, named the teriparatide, alboparatide, and romosumab. Now, mechanism of action for us to understand how an antiresorptive agent interrupt the bone modeling cycle at cellular and molecular level. So, the bisphosphonates target the osteoclast. We have the nitrogen containing bisphosphonates and the non-nitrogen containing bisphosphonates. The nitrogen containing bisphosphonates are the alendronate, risedronate, zoledronic acid, and ibandronic acid. They inhibit the farnesyl phosphatase synthesis and disrupt the osteoclast cytoskeleton and the osteoclast apoptosis. The non-nitrogen containing bisphosphonates, ethanoate and chlorinoate, commonly used in Canada and in the European countries, incorporate into the hydroxyl ATP analogs the osteoclast cell death via metabolic disruption. They cause the death of the cell. Here they disrupt the osteoclast function. So the key pharmacological feature is the high affinity of hydroxyapatite is retained in the bone for years after discontinuation, the basis of residual effect enabling drug holiday. So what does this mean? Whenever you give a nitrogen containing bisphosphonates, they go sit into the bone in the hydroxyapatite and they are there for a very long period. So even if you give a treatment of an zolantanic acid, it works for a year. You give a cycle for 2 or 3 cycles, and after that you stop. The residual effect continues for a long period, and that they use it as a drug holiday. The rank ligand, that is the denosumab blockade, fully human clonal IgG2 antibody target the rank that prevents the rank ligand rank interaction, which is essential for osteoclast differentiation, activation, and survival. It acts at all the skeletal sites, including the cortical bone, the rapid onset, potent suppression of bone turnover markers, and no skeletal retentions. Effects are fully reversible on discontinuation. Unlike the unlike the nitrogen-containing bisphosphonates, these drugs cease their effect when you stop it. So when you stop this drug of denosumab, you have to follow it up with another drug to maintain the bone. So that becomes the need, and you have to keep giving this at frequent intervals of every 6 months. The critical distinction from bisphosphonates is withdrawal of denosumab results in overshoot of bone turnover and leading to bone loss, creating a lot of rebound fractures. So when you give zolantanic acid or any of the nitrogen containing bisphosphonates, you stop it for a year or two, that effect still continues. Whereas with denosumab, which is a rank ligand, the moment the drug is stopped, the bone turnover increases and the chances of rebound fracture is much higher. The selective estrogen receptor, the calcitonin and the hormone replacement therapy, it has got its own effects. Estrogen receptor agonist in the bone, it reduces the osteoclast activity. It's an agonist in the breast and uterus and reduces the antagonist in the breast and uterus and reduces the vertebral fractures by 30%. But there is no proven effect in fracture benefits. This drug is not used nowadays because of the side effects, or because of vascular thromboembolism or other adverse side effects. They don't use it. The other drug is a class human hormone receptor treatment, that is estrogen. They suppress the rank ligand expression effectively in peri and early postpartum episode. So once early menopause or perimenopause, it's effective. Later, it may not be that effective. The non-bone effects must be carefully weighed. That is the vascular thromboembolism and the breast cancer. You cannot give it for a long time. Then, calcitonin is a drug which inhibits the osteoclast activity via the calcitonin receptor. It is a modest anti-fracture efficacy, analgesic benefit in acute vertebral fracture, and limited role in current guidelines. It is mainly used as an analgesic. When a person comes with an acute fracture, you give it. It may not have much of an anti-resorptive effect. It may not have an anabolic effect, but it inhibits the pain. So the analgesic effect is much more useful in patients who have acute vertebral fractures and limited role in guidelines as it is. So the next question is indication and patient selection. Who are the patients who need antiresorptive, who needs an anabolic, who needs a continuous therapy, and who needs a concurrent therapy? So who needs treatment? When you have osteoporosis diagnosis of T-score of minus 2.5 at the spine or the hip, or a frax of 10-year major fracture more than 20, or hip more than 3% as per the ASBMR guidelines, or a very high fracture risk when the T-score is less than 3, or a frax more than 30, consider an anabolic or a potent antiresorptive. So when the T-score is less than 3, use an anabolic agent. Antiresorptives won't help you that much. So how do you get the T-scores? By the standard diagnosis by DEXA. A DEXA is to be performed before starting the work of treatment. When it is minus 2.5, the spine or hip confirms osteoporosis and triggers treatment considerations. And if you have Frax tool, use a 10-year probability of major osteoporotic fractures more than 20 or hip fracture more than 3% meets the ASBMR treatment threshold. Very high risk, prior fracture fragility, T-score less than 3, Frax major fracture more than 30 as per ASBMR guidelines. Goal directed towards a framework and consider anabolic agents as a first line of therapy and the most potent antiresorptive agents if at all you were to add. Who are the special populations who require antiresorptive therapy? Those who have got glucocorticoid-induced osteoporosis. Those who are on prednisolone more than 5 milligrams per day for more than 3 months, initiate the bisphosphonate. Zoledronic acid is preferred if the GA intolerance and adherence is concerned. If you want, you can give oral bisphosphonates, otherwise zoledronic acid. Aromatase inhibitor therapy, bone loss of 1 to 3% on aromatase inhibitor therapy. Antiresorptive is indicated if the T-score is less than 2.2 or a high FRA score or an annual DEXA essential. Androgen deprivation therapy, rapid bone loss with that is used in denosumab. Mostly people with hypogonadism, they will do better and is approved specifically for fracture prevention in prostate cancer. Osteoporosis versus bone metastasis, different goals. In osteoporosis, you use denosumab once in 6 months. Bisphosphonates as a standard osteoporosis dose. Goal is prevent the fracture and BNB preservation. Whereas in bone metastasis, denosumab is used in double the dose given monthly. Zoledronic acid given every 3 to 4 weeks. The goal is to skeletal related event prevention. So you're preventing the metastasis here. So you have to give a higher dose, double the dose of denosumab given monthly, or zoledronic acid given every monthly also. So practical guidance for dosage. Alendronate is 70 milligrams once weekly. After taking the tablet, you have to be in upright position 30 minutes before food, most widely used. So get up in the morning, take this tablet, sit down straight, don't move for 30 minutes. You can keep doing your activities like computer or table work or anything. Whereas no eating food. Risendronate, same way. If you want to give it 35 milligrams weekly, 150 milligrams orally by monthly weeks, better GA tolerability than alendronate. Zoledronate is probably the best, I would say, 5 milligrams. Give it yearly. Preferred for adherence issue. The only thing is, people who have GA tolerance, they are much less. You may have features of myalgia and fever after the infusion. Post hip fracture, if you infuse within 15 minutes. Ibandronate is 150 milligrams per orally for 3 milligrams, monthly for 3 doses. No preborn hip fracture risk, limited role in high risk patients. How do you give denosumab? Administered by a healthcare provider, ensures compliance, no dose adjustment required for renal involvement. Delayed injection beyond 4 weeks creates rebound bone loss. Calcium and vitamin D supplementation mandatory before and throughout the therapy. Adherence is not optional. Even delayed doses in a clinical event, track injection dates actively and schedule the next dose at every appointment. Monitoring the drug quality and treatment duration. Bone densitometry has to be repeated once in every 2 years. If stable and improved, later on every 3 years. Document the absolute BMD values, not just a T-score to track the response. This is the most important to say that whether you improved or not. Calcium and vitamin D, correct that before giving. In India, we have vitamin D deficiency and calcium deficiency. So it becomes imperative to give treatment along with that. And monitor serum calcium, especially when you're giving denosumab, and target a vitamin D of more than 30 nanograms. This is in nanomoles. Bone turnover markers, CTX resorption marker, P1 and P formation marker. Measure every 3 to 6 months to assess the adherence, absorption, and pharmacological response before DEXA is detectable. So you find the DEXA changes after 1 year, whereas the CTX P1P changes you find in third and sixth month. A dental review before initiating long-term or high antiresorptive therapy. Annual dental review recommended. The drug holiday. When do you give a drug holiday? how long will you give a drug holiday? The FLEX trial demonstrated continued vertebral projection beyond 5 years with T-scores between -2 and 2.5. The holiday benefit is stratified and it is not universal. If you continue beyond 5 years, if the T-score is less than 10, prior vertebral fractures, ongoing high-dose glucocorticoids. Holiday duration for 2 to 3 years. If you give zoledronic acid IV, 3 to 5 years residual effect resume if new fracture or significant BMD decline. So, which means if you're giving oral bisphosphonates, every 2 years or 3 years, you'll have to do a BMD. Same thing with the zoledronic acid. If you give it every third year, we'll have to see if the BMD is declining, you'll have to repeat it. The skeletal retention of bisphosphonates provides ongoing protection during a structured holiday. This is a pharmacological basis of past strategy. So, denosumab, there is no drug holiday. There is only a transition plan. Last dose of denosumab, exact date at every injection. Next dose due within the next 6 months. Rebound, rank reactivation begins 6 to 12 months post dose. So if you have stopped the dose at 6 months, you will find the fracture coming only in the next 6 dose. So you will have to give it by every 6 months. That is the basis of giving denosumab every 6 months. Osteoclast precursor reactivates en masse. Accelerated bone loss and fracture cascade will occur. You can transit from denosumab to bisphosphonates. Administer zoledronic acid within 6 months of the last denosumab. Single dose may be sufficient after prolonged denosumab exposure. Monitor the bone turnover markers, CTX suppression, and look at it as I told you. The CTX is a resorption marker. This is what you are looking for. Is the bone resorption happening? And P1NP is a bone formation marker. So you should keep concentrating on the resorption marker whether resorption is increased. And repeat at the end of 3 months post-zoledronate to find any rebound prevention has occurred or not. Unlike bisphosphonates, skeletal retention does not occur with denosumab, and the suppressed osteoclast precursor reactivates simultaneously when the rank blockade is lifted. So never discontinue without a transition plan. So what are the adverse effects? Recognizing and monitoring and managing the most clinically sufficient complications of antiresorptive therapy, the osteonecrosis of the jaw, exposed necrotic bone in the jaw persisting for more than 8 weeks, not explained by radiation or metastasis, is the definition of osteonecrosis. You have a necrotic bone which is seen for more than 8 weeks, not explained by radiation or metastasis. Very, very rare osteoporosis doses 0.01. 1% of patients with oncology will get osteonecrosis. The dental extraction, poor oral hygiene, steroids, diabetes, and smoking, duration of antiresorptive therapy. Prevent dental evaluation and treatment before initiating therapy. So you get a dental evaluation done before you start the therapy. Avoid invasive dental procedures during treatment whenever possible. Atypical fracture femurs, by definition, their transverse or short oblique fractures of subtrochanteric diaphyseal femur with minimal or no trauma. 3 to 50 per 1 lakh patients increases with duration, rises sharply 5 years beyond bisphosphonate use. So most of the bisphosphonates we stop below before 5 years, it doesn't occur. Prodromal thigh or groin pain, lateral cortical baking or thinning on a plain X-ray. Do not miss this prodrome. So a person who is on antiresorptives, especially the bisphosphonates, complaints of thigh or groin pain, take an X-ray, you will find lateral baking or thinning on a plain X-ray. Do not miss. This is the earliest sign. Discontinue antiresorptive immediately. Bilateral X-ray, 30% are bilateral. Orthopedic referral, consider teriparatide as a healing therapy. So ask about thigh or groin pain at every clinical visit in patients on long-term bisphosphonate therapy. The prodromal period offers a critical window for intervention before complete fractures. Hypocalcemia can occur with denosumab, especially when the patient is CKD. Correct the vitamin D deficiency and ensure adequate calcium intake before dose. Acute reaction, flu-like symptoms with zoledronic acid. Pre-medicate with acetaminophen resolves within 72 hours, attenuates with subsequent loss. GI effects, the oral bisphosphonates, esophageal irritation, dyspepsia, strict administrations are essential. Fasting, upright positioning, 30 minutes before food, full glass of water. Renal consideration, avoid IV zoledric acid. Less, if the GFR is less than 35 and infuse over 15 minutes, denosumab requires no renal adjustment but increases the risk of hypocalcemia. So we'll give six detailed studies in real world decision making for changeover therapy. You have a postmenopausal woman with vertebral fracture with renal impairment, 68-year-old with L2 compressed fracture with DEXA spine at minus 3.1 and the hip minus 2.5. GFR is 42, mild renal failure. So renal impairment precludes the IV zoledric acid, oral bisphosphonate adherence uncertain after fracture. Decision is denosumab, no renal adjustment is required. Calcium 1000 milligram plus vitamin D. Dental clearance applied prior to the first dose. Outcome, roughly about 8% weight gain on the spine and 4% weight gain at the hip. No new fractures. Bone turnover markers are normalized at the 6 month. Transition to bisphosphonates planned proactively before any potential denosumab discontinuation. Key lesson, denosumab is an antiresorptive choice when renal function limits bisphosphonate use but require a mandatory transition plan. Second, 72-year-old woman or on denosumab for 5 years. Patient discontinued without informing the physicians. 8 months later, 3 new vertebral fractures. CTS is elevated because the antiresorptive effect is gone. The rank-lying event activation simultaneously osteoclast surge, accelerated bone loss and fracture cascades, trabecular bone deterioration from a single missed injection can trigger multiple spontaneous vertebral fracture is a well-documented rebound phenomena. So one fracture will trigger many things. Management here is zoledronic acid administered urgently, aggressive pain management, vertebroplasty, bone tonal markers monitored 3 and 6 months. Non-negotiable rule, always plan and document a bisphosphonate transition strategy before stopping denosumab. Abrupt discontinuation is a medical error. Educate the patient on every injection. Third, glucocorticoid-induced osteoporosis in a person who is taking 10 milligrams per day of prednisolone for 2 years in a patient with rheumatoid arthritis who has a bone density of minus 2.3 hip and minus 1 hip. Prax possibility of 18%. GFR is normal, low complication. Drug zoledronic acid preferred glucocorticoid for superior adherence and established efficacy. Calcium and vitamin D supplementation initiated concurrently. Outcome at 12 months, BMD spine plus 5.4, no incident fractures, prednisolone tapered to 5 milligrams a day, and bone turnover markers is normalized at the third month. Annual dental review is rescheduled. So you use zoledronic acid, prednisolone has to be tapered in patients with glucocorticoid osteoporosis. Atypical fractures in long-term alternate weekly good adherence, annual DEXA stable, no prodromal symptoms reported. Then at the 6th month, right side thigh pain reveals lateral cortical thickening. This is a prodromal atypical fractures, femur confirmed. Immediate action, islanded discontinued, contralateral X-ray is to be done, which is seen bilateral 30%, orthopedic referral, intramedullary draining considered, transition to bone forming agent, anabolic agent, initiated to promote bone healing, antiresorptive need assessed at 18 months post anabolic closure. So a 74-year-old woman with this pain will have the possibility of this. Now, the aromatase inhibitors in patients who are treated with breast cancer and letrozole, baseline DEXA is in normal limits. On follow-up, it becomes minus 2.5 per year. So the hip also becomes accelerating bone loss. Zoledronic acid is initiated along with calcium and vitamin D. Weight-bearing exercise is prescribed. Outcome at the end of 2 years. BMD stabilizes at both sides. No incidental loss. Letrozole continued without interruption. Oncology goals are preserved. So for breast cancer, you have an aromatase inhibitor which you are giving letrozole that can lead on to bone loss. So manual DEXA is mandatory in all patients with aromatase inhibitors. Do not wait for symptoms. Osteonecrosis of jaw in oncology setting in a person who is using denosumab 1000 to 120 milligrams subcutaneous daily, monthly, for a period of 18 months. Dental extraction performed without denosumab team notification. Exposed jaw for 10 weeks. Osteonecrosis of the jaw confirmed. Oral antibiotics, chlorhexidine rinses, conservative debridement by oromaxillary surgeon. Denosumab reduced with bone tumor markers guiding monitoring. Mandatory dental clearance has to be done before starting antiresorptive therapy. Elective dental procedures must be avoided throughout the treatment. Dose distinction 60 to 120 milligrams changes the risk profile. Sequential and combination therapy. As I told you, long-term preservation requires transition plans. Anabolic first, antiresorptive leaves. So, anabolic first, romosozumab or teriparatide, antiresorptive consolidation with zoledronic acid. Spine BMD goes by 13%. Standard high risk antiresorptive first, which is given. Bisphosphonates and denosumab. Add an anabolic if inadequate. Yes, the ASBMR recommendation. Very high risk fractures with a prior TS score less than 3 and a frax figure of more than 30. Anabolic therapy first for maximum BMD gains must be followed immediately by antiresorptive therapy. Why sequence matters? Romosozumab leading to denosumab and zoledronic acid. The gain at BMD at plus 13% at 12 months, gains lost without antiresorptive. If you don't give an antiresorptive, the effect of this is lost. So antiresorptive to anabolic. Less effective, prior bisphosphonate use bloods terrified response. So long-term sequential therapy, establish baseline category of DEXA, BTM, bone tumor markers, frax history, classify as a high or low risk patient. Select the patient. Antiresorptive for most anabolic effects first. Document the rationale, state the date and plan duration of initiation. Monitor and reassess the DEXA and bone tumor markers. New fracture and therapy, treatment failure, reassess immediately. Plan transition proactively. Drug holidays or bisphosphonates must be planned, not reactive. The Asia Pacific consensus of American Society of Bone Research both emphasize planned sequential strategies. Lifelong disease management. Osteoporosis is a chronic disease. Treatment is lifelong, and most high-risk patients document transitions, assumptions, and rationalize at every encounter. Goal-directed therapy. Reassessment triggers new fractures on therapy, treat as a treatment failure, significant BMD decline more than 5% despite therapy, BMT not suppressed at 3 to 6 months, adherence or absorption problem, annual fracture risk assessment regardless of stability, keep watch the T score if it is more than 2 or a bone turnover marker, the resorption turnover marker CTX and PNP, whether they're within the range. Beyond the T score, all plans require calcium, vitamin D, weight bearing and resistance exercise, risk fall assessment, and mitigation of every visit. Clinical takeaway, first line of treatment are bisphosphonates with a structured holiday of 3 to 5 years. Skeletal retention provides ongoing projection. Denosumab, potent and renal safe, ideal when the bisphosphonates are contraindicated. Never stop abruptly. Always transition to bisphosphonates to prevent the rebound fracture. Monitor proactively the bone turnover markers, dental health and screening, and the renal function. Address every clinical encounter. Individualize always the renal functions, fracture history, comorbidities, and patient preference. Drive against selection. No single algorithm fits all. Treat the disease. Fracture prevention is the ultimate goal, not just improving a T-score number. A chronic disease demands a structured management therapy. So that's the end of the whole thing.
Sir, our audience have asked few questions that I
Yeah,
have put
yeah.
it in the chat
Most
box.
welcome.
Yes, sir.
Yes, sir. What are the questions we can
So,
have?
yes, sir. The first question is, how do you decide between initiating an anti-resorptive versus an anabolic agent
Can
in a
you be
newly?
louder, please?
Yes, sir. Yes. So the first question is, sir, how do you decide between initiating an antiresorptive versus an anabolic agent in a newly diagnosed high-risk patient?
If a patient has a T-score of less than 2.5,
Okay. Yes, yes,
straight
yes.
away, let's straight away use an anabolic agent. That's how I follow. If you have a T-score between 1.5 to 2.5 minus, then you follow giving. Where is this? You can see me?
Yes, yes, sir. We can see you. T score is, sir, minus. It's above minus 2.5.
Huh. Yeah,
So
minus 2.5.
yeah. And sir, next question is CKD a limitation for teriparatide therapy, or can it actually be an advantage in selected patients?
Teriparatide major as does not have, but I think when you have in those patients with bone loss because of renal failure, the resorption needs also to be prevented. So teriparatide may be a better option, but in majority of the patients, you can give the antiresorptives also. Well, if the T score is very high, minus, we can continue with the anabolic agent.
Okay. Thank you, sir. Rest things you have cleared already in the presentation. Thank you so much, sir.
Anything else? You want me to be online? Rahul,
Yes, sir. Yes, sir.
you want me to be online?
No, no, sir. Now we can close the session also. I think
Okay.
most of the query has been completed.
You can wind up the meeting.
Okay. Okay. Thank you, sir. Thank you so much, sir.